Greetings to my colleagues from the Philippine Society of Endocrinology, Diabetes, and Metabolism, and welcome to my fellow healthcare professionals and clinical educators. For this session, we will focus on the patients with hypertension, and I hope to impart to you some of my personal takeaways for clinical practice. To help me do that, I have outlined three simple objectives. The first is key concepts. What are the things that we need to understand when talking to the patient who has hypertension and those who have elevated CV risk? Secondly, drug therapies. What are the reasons why we choose particular medications for these patients? And finally, single pill combination. How effective is this particular strategy in helping us afford better care to our patients? Let's start with a hypothetical clinical scenario. We have here a 55-year-old male with mild renal insufficiency, admits to smoking cigarettes, has occasional chest pains, and has very high blood pressure without medications. But before we even talk about medications, it is important to have that very necessary discussion about assessing the patient's cardiovascular status or CV risk profile. What are the things that matter not just to the doctor, but also to the patient? At the get-go, we will recognize that this is a patient with a lot of uncontrolled cardiovascular risk factors. Throughout the presentation, I will outline some of my personal takeaways in clinical practice. The first, and probably one of the most important, is for us to emphasize to the patient the clinical burden of disease. As we speak, many patients all over the world continue to die of complications of uncontrolled blood pressure levels. So hypertension is not just a number, it is a signifying indicator of some clinical event or propensity for it. At the local front, we will recognize back in 2013, Pression 3 put the hypertension prevalence at 28%. So roughly 1 out of 3 Filipinos will have a blood pressure problem. But we also need to be mindful of local epidemiology. Curiously, Central Visayas lagged in the highest prevalence at 35%. But 2 islands away is Western Visayas, which had the lowest. What are the reasons for this disparity? Could it be access to medications, physician prescribing patterns, or maybe health-seeking behavior of patients? Not to mention, of course, culinary differences. NCR is always up there, and including even Central Luzon at 34%. We also need to recognize that when we see a patient with hypertension, this is not an isolated medical matter because majority, if not all, will have a lot of concomitant comorbid conditions such as dyslipidemia or what we call lipitension, and even some form of renal insufficiency or chronic kidney disease. The second important takeaway is for us to ensure an accurate and timely diagnosis. Not all patients with elevated BPs have hypertension. Only those who have persistently elevated BPs should be labeled to have the pathology of hypertension. Many of our patients actually have what we call white coat hypertension. And when the BPs start to go back to normal, when they leave the clinical or hospital setting, that is a clue to possible white coat. A third, not too common but equally important entity is masked hypertension. These kinds of patients come to your clinic very relaxed and at ease, have developed rapport with the doctor. BPs are normal, but when they go back to their very stressful environment at home or at work, blood pressure shoots back up. Please remember, true hypertension, white coat, and masked hypertension to avoid the knee-jerk response of treating right away. And how do we now diagnose patients to have hypertension? Our job also is to educate the patient that the traditional way to diagnose is through clinic or office BP using multiple measurements. In some instances, we do not catch the hypertension, so we need to strap the patient to a device, and this can be strapped on for 24 to 48 hours, an ambulatory blood pressure monitor. And finally, of course, very important now during the pandemic, involving the patient in their care, home BP monitoring using your digital devices. It's very important to improve the way patients become partners in their healthcare. That is why we emphasize out-of-office BP measurement to help us confirm the diagnosis, to detect the various entities I have mentioned, and to help us assess adherence to therapy and effectiveness of BP control. So much so that all patients that we see in the clinic, all adults for that matter, should have at least an initial BP determination. And the BP entry will help us decide how aggressive and how frequently we will monitor such patients. Third takeaway, the 3 T's. One quick tip for my younger colleagues and trainees is to remember 3 T's in helping digest voluminous guidelines. The first T, threshold, answers the question whether the patient should be diagnosed with the entity or hypertension. Trigger answers the question, when should we start pharmacologic therapies? And finally, target answers the question, how low should we go? What is our target? Please make sure to make an effort to discuss these 3 T's with your patient to improve adherence. Now, talking about guidelines, of course, we know that there are American guidelines in 2017. As far as hypertension is concerned, the European in 2018 and the International Society of Hypertension in 2020. But as a Filipino clinician, we also need to be mindful of locally developed guidelines. Back in 2011, we had the 140/90 report spearheaded by our very own Dr. Nelson Abelardo in the Philippine Society of Hypertension. So the threshold will help us easily distinguish at the get-go that Americans pushed back the threshold to 130/80, while the Europeans kept it at 140/90. In terms of triggers, the Philippine update made special mention of the high-risk population, saying that patients with a lot of CV risk factors will have a lower threshold for initiating therapies. If we pull out this image from ESH, it is easy to simplify by saying that your patients can be dichotomized. On one hand are the patients that have maybe borderline BPs, not too many risk factors, and most of them asymptomatic. We have time to risk stratify. And at the other end of the spectrum are the patients that come in with sky-high blood pressure levels, very symptomatic, a lot of severe risk factors, many of them getting admitted to the emergency room. We will be justified to treat right away. As far as the 30 is concerned, the targets, most guidelines will converge by saying we need to bring it down to a clinically tolerable level, while the ESC makes special mention for the elderly. ISH of 2020 extends it even further by saying that there is a desired magnitude of BP reduction that we should strive for. Now, talking about assessing CV risk, there are a lot of ways to assess the cardiovascular risk of our patient. You might be fond of your clinical calculators from the Americans, the score chart or heat maps from the Europeans. There is a third strategy called the vascular age, which actually helps us understand how the arteries of a human being behaves. And finally, risk counting. Let's just ask the patient, do you have hypertension, dyslipidemia, do you smoke? Any of these particular strategies are acceptable, but it will really depend on the physician how to explain these strategies to the patient. The important thing to remember is we need to have that discussion about global CV risk. And when we talk about CV risk, I always like to quote one of the most important global case control studies to date, the InterHeart study led by Salim Yusuf and, of course, our very own Tony Dance. This very large global case control study looked at patients all over the world, trying to determine the relationship between 9 traditional and non-traditional risk factors for a first heart attack. This was published back in 2004. To help simplify the discussion and for you to take away some important information, this forest plot demonstrates that there are certain risk factors that seem to elevate one's chances of having an MI, and there are some that seem to protect us. To help remember, just try to recall the 9 T's, the notorious 9. Tobacco, tamis, taas presyon, tambok, talas or tatag, tanim, tagtag, tagay, and taba. Remember that having a few minutes of discussion about the 90s can really give you a pretty good estimation of this patient's overall CV risk profile, even in the absence of very refined calculators. So remember the 90s. And talking about non-pharmacological therapies, there are a lot of strategies that have been proven already to help bring down your blood pressure levels. And I will enumerate some of the more important items: moderating alcohol, increasing potassium in the diet, trying to achieve weight loss, reducing the salt content in your food, engaging in regular aerobic physical activity, and finally, of course, adopting a healthy diet. Take note of the magnitude of benefit as far as systolic BP reduction is concerned, the class of recommendation, and the strength of evidence, all in support of these 6 non-pharmacological therapies on top or even outside of drugs. This is very important to really impress upon the patient that they can do a lot of things to improve their health. Now, how do we choose the medications for our patients? Let's go back to this clinical scenario. For some reason, this patient gets hold of very accessible ARB like losartan, still with suboptimal BP control. He already stopped cigarettes, which is very good, but still has some occasional chest pains. Okay. So one thing that we can also remember is trying to understand what is happening to this patient or to this patient's body. And I would bet that majority, if not all of our patients with hypertension will satisfy any of at least one of the following mechanisms. You might have the young patient with hyperadrenergic drive. You may have the patient with busted kidneys, high renin levels, responsive to RAS blockers. You might have the young female with low potassium, high BPs, maybe some secondary hypertension issues. And finally, of course, the classic stiff arteries of our senior citizen patients due to elevated peripheral vascular resistance. When you look at this patient that way, it is much easier now to justify, not just to the patient, but to you, to yourself, that what you are prescribing is going to work. So in terms of pathophysiologic basis, you will see here, one important thing to remember as we grow older or age gracefully, some renin levels will actually drop, explaining why younger patients respond better to RAS blockers, while elderly patients would need add-on therapies like your powerful vasodilators, your calcium blockers. And back in 2011, the NICE guidelines already suggested a simple strategy, remembering the alphabet A, C, and D, an ACD approach. And we will go back to that very shortly. Next, another important takeaway, we need to espouse treatments that have scientific evidence. Okay, so let's talk about the evidence. And the spread of trials out there on hypertension have demonstrated some key landmark trials that seem to put into the spotlight particular drug therapies. In particular, ASCOT demonstrated the superiority of this drug combo, an ACE inhibitor and CCB, versus a comparator, which is, of course, a beta blocker and your thiazide diuretic, as far as CV outcomes. So we are not just concerned with bringing down the BP, we are also trying to prevent cardiovascular outcomes. And remember HIVET, that trial for our very senior or super senior population, and in the spotlight was actually your thiazide-like diuretic indapamide. The HIVET trial demonstrated the value of this particular diuretic in preventing strokes, which is a key issue also in hypertension in the elderly. You will remember ACCOMPLISH. This ACCOMPLISH trial also again reinforced the value of combining your ACE inhibitors and CCBs over that comparator, which is an ACE and a thiazide diuretic as far as CV outcomes. So it seems like the A plus C combination really is very attractive. An ACE inhibitor and a CCB. And of course, down the line, you will hear about the newer trials that really tried to mold the landscape of BP treatment. So when we think about the ACD, remember the ACE or ARB, the calcium blocker, and your diuretic. Let's talk about the RAS blockers. Well, mechanistically, they are really different. You will see here in summary, the blue benefits on the left for your ACE inhibitors and on the right, the blue benefits and the red negative impact of your ARBs. Different mechanism of action, and that is why they are not the same. If you want further evidence in support of which particular RAS blocker to choose, you will see here that ACE inhibitors actually trump your ARBs in terms of anti-inflammatory effect, even your anti-apoptotic effect. And of course, you want to look at your trial evidence and looking at the conglomeration of various trials out there for ACE and ARBs. In summary, you will realize that there are trial outcome benefits for ACE in terms of the following endpoints: MIs, CV death, and all-cause death, which means science will really back up the utility of ACE inhibitors in treatment of patients with hypertension. Moreover, remember your advanced trial, one of your favorite trials out there, which demonstrated the impact of ACE inhibitors in terms of reducing these endpoints: total mortality, CV mortality, coronary events, and even renal events and microalbuminuria. So a lot of benefits on top of BP control. Now, how about for your calcium blockers? Well, we know for a fact that your good old amlodipine is a very powerful vasodilator, and it was also studied in patients to mitigate the risk of stroke. And look at how amlodipine really provided incremental benefit for your therapies. And for the letter D, what is the diuretic of choice when we talk about hypertension? Well, there are the thiazide type, represented by hydrochlorothiazide. Your thiazide-like, represented by very old drugs, chlorthalidone and idapamide, but still pretty powerful. And finally, your non-thiazide, like your loop diuretics, furosemide. Okay. And if you're going to choose a particular diuretic, we go back to the evidence, the mechanistic and the trialistic evidence. Look at how indapamide actually demonstrates superior BP lowering efficacy, 24-hour control, and to some extent, metabolic neutrality and the add-on benefit in terms of clinical event reduction. So if you're concerned about stroke prevention in your elderly patients with hypertension, again, the thiazide-like class of diuretics will definitely trump its competitors, the thiazides and the thiazide types. Next takeaway, we need to tailor the approach of patients with hypertension. And I would dare say that the best piece of evidence is not the paper nor the guideline, but the person seated across your clinic desk, the patient. Look at the patient and what is the constellation of CV risk profile as well as comorbid conditions. The ESH actually advocates now for drug-naive patients with uncomplicated hypertension. It is a good strategy to start a single pill containing two molecules, a dual combination SPC. And what are the components of this dual combo SPC? Your RAS blockers, your letter A, and possibly a CCB or a D. If that strategy does not work, then you can consider escalating still a single pill with 3 moieties inside. If that doesn't work, then be keen on picking up possibility of resistant hypertension, most especially if you have diuretics on board. Now, how about patients with hypertension and atrial fibrillation? Yes, RAS blockers will still be at the core of the treatment strategy, but you might want to throw in a rate controller such as your beta blocker or your non-dihydropyridine CCB. For patients with chronic kidney disease, again, RAS blockers are still part and parcel of therapy, but you might want to add on a CCB or a diuretic. For patients with coronary artery disease, again, ACE or ARBs in the center, maybe an add-on beta blocker, most especially if this patient is post-MI, and possibly a diuretic or a CCB. For patients with very weak hearts or heart failure with reduced ejection fraction, Again, RAS blockers at the center. Then depending on the patient's hemodynamic status and volume state, you might want to consider a diuretic and a beta blocker once fully stabilized. 2020 ISH essentially echoes what I have outlined for you in the past several slides, that at the core of the treatment strategy are your RAS blockers. Let's go back to this patient. This patient somehow was shifted to an ACE inhibitor, and there are a lot of choices in terms of optimizing care. Do we stay on monotherapy and escalate the dose? Do we add another drug? So we will see right now that yes, monotherapy is still acceptable, but it is in no way similar in terms of clinical impact versus combined therapy in terms of protecting your patients from any CV events, ischemic heart disease, strokes, heart failure, even arrhythmias. To further drive home the point, back in the day when I was in training, the prevailing norm was a step care approach. You start one drug, you escalate the dose, add another drug, escalate, and add the third, and so on and so forth. Right now, we are seeing an era where we can start at the get-go an SPC right away to demonstrate early on the benefit and to demonstrate that this benefit actually pervades over time. Look at how combination therapies will really work for our patient. Remember incremental benefit. An add-on perindopril will have add-on benefit, and an add-on CCB on top of these two will also redound to superior CV event protection. That is for stroke, and that is also true for cardiovascular disease, taking note of these key landmark trials out there. Now, winding down, let's talk about the SPC approach. For some reason, this patient probably gets lost to follow-up, comes back to you with more medical conditions, maybe higher pill burden, and for some reason was also on an SPC, but BP is still not yet too good. So there are a lot of other options out there. You might want to escalate the individual doses, or you might actually consider adding a third molecule to that SPC. And why do we want to concern ourselves with polypharmacy? Why? Because the more pills there are out there, more side effects, more confusion for the patient, and maybe less adherence. If you look at the history in terms of the polypill concept, I will pull out again one of my favorite studies. Interheart in 2004 probably explains very well why a polypill concept is such an attractive strategy. Because patients with hypertension don't just come in with that problem. They will have a constellation of other medical issues. That is why it is a logical strategy to consider treatments that will attack not just one, but multiple issues as well. And so much so that the following year, the polypill concept was somehow introduced with a little bit of controversy. And remember, ASCOT trial was actually probably one of the first, if not the first, landmark trial that looked at outcomes for combo drugs, which means prior to ASCOT, many of the trials focused on head-to-head monotherapies. What is the basis for thinking about this combination, your A, your C, and your D? Well, look at the complementary pharmacokinetic profile and how each individual agent will attack various elevations in your blood pressure and how they can be administered in a single dose fashion. So back to this patient, maybe it is a worthy option to consider an SPC approach. If you need more than one pill, maybe combine certain agents in a single physical pill, not just to bring down the BP, but really to address other issues. And when I talk about other issues, we wind down to my final two takeaways. When we treat patients, we don't just bring down the number, we try to relieve them of the symptoms, help them mitigate the cardiovascular risk, make sure that they don't end up in the hospital for events, and ultimately help them improve their quality of life. And again, how do we do that? Of course, we consider the strategies that work for us in terms of blood pressure, effective blood pressure control, and even those that will help us avoid events and improve adherence for our patient. So finally, one last takeaway is, of course, to proactively identify what are the barriers in achieving optimal BP control. And these are the following. And I believe that an SPC approach might really be an attractive strategy to address precisely these particular barriers. So hopefully at the end of this session now, we can bring home certain key concepts, and I would focus on being aware of local epidemiology. In terms of second objective, we need to also recognize what is the underlying pathomechanism happening in this patient. And finally, we do not concern ourselves just with numerical reduction. We think about quality of life, symptom reduction, and everything else will fall into place. Because at the end of the day, for me, SPC is simplifying patient care. Thank you very much for your attention.